Good morning. Welcome to In the Trenches with DAC. Today's topic is going to be post-MI care, post-MI complications. It should be noted that I did not prepare for this. I am doing this off the cuff. Okay, first concept here with MI, time equals muscle. Second concept, muscle equals prognosis. Okay, so what does time equals muscle mean? The quicker you intervene and lessen the severity of the MI, the more muscle you preserve, the better the prognosis will be. The more myocardial damage, the worse the prognosis, the increased chance of death. That's the core concept here. I started my training in 1983. And that's before they had a lot of the tools that they have now, although they were using intravenous streptokinase and intravenous TPA. This was the beginning of it. Now a patient will come into a hospital with an acute MI if it's a STEMI, and they have the resources, they will go right to the cath lab and get a PCI or possibly even surgery. And if they have a non-STEMI, they may or may not go to the cath lab right away, but the intervention will occur soon. So let's talk about post-MI complications. The first thing you need to think of are the mechanical complications. For years, they always ask these on the internal medicine. I don't know if they still do that. Okay, ruptured intraventricular septum, ruptured papillary muscle, cardiac tamponade, and right ventricular infarction. So these are the four mechanical complications. Ruptured intraventricular septum, it's muscular, not membranous, and it usually occurs about over 2/3 of the time with anterior wall MIs. The septum blows out and you have blood going from the left ventricle into the right ventricle, and this could cause hemodynamic collapse. You would diagnose this, besides echo, with a Swan-Ganz catheter, right heart cath, looking for O2 step up. Cardiologists will do this. Ruptured papillary muscle, more common with inferior wall MIs. The papillary muscle, anterior leaflet of papillary muscle is dual blood supply. The posterior leaflet is single blood supply by the posterior descending artery, and you could blow out this valve and you could have acute pulmonary edema and acute mitral regurgitation. Cardiac tamponade, usually with anterior wall MIs, where the free wall ruptures and you have tamponade, and this is an emergency and this is handled a different way. You may diagnose this physically, confirm it with echo. You may need pericardiocentesis and a window. Right ventricular infarct you see with inferior wall MIs. The key here is it's an inferior wall MI. You have a low blood pressure. Okay, the lungs are clear. They're not in pulmonary edema. Okay, and sometimes to diagnose it, you actually, besides inferior wall changes on the EKG, you get a cardiogram with reads V3R and V4R, okay, and they will show abnormalities. These are the mechanical complications. Now, because MIs are smaller now because of more rapid intervention, we don't see these as much. Of note, during the heart of COVID about 2 years ago, people were not coming in right away with MIs, and they were seeing more of these mechanical complications. Okay. The next complication posed to peri-MI is ventricular tachycardia. Okay, now obviously VT is a lethal arrhythmia. Okay, and one of the ways people die post-MI late is via sudden death due to VT, and often they identify higher risk patients and they stick defibrillators in them. Acutely, you could get VTAC, and if you have a VTAC acutely, it's not necessarily you need a defibrillator. These people need to be treated with IV amiodarone or IV lidocaine. Okay, having an arrhythmia in the first 2 days of an MI is not the same as having it a couple weeks or a month later. But you have to be on the lookout. You have to be on the lookout for these arrhythmias. Okay, another complication is pericarditis. So somebody could have chest pain post-MI, and it might not be an MI. Now you have acute pericarditis, usually with large anterior wall MIs, and then a couple weeks to 6 months after, you could have an immune-mediated pericarditis, which is called Dressler syndrome. Okay, and these are going to be treated. You're going to be treated with colchicine. You know, you're going to try and avoid steroids. Usually with pericarditis, you could give high-dose ibuprofen. That's not great in somebody in the setting of an acute MI. But pericarditis is a complication. Okay, another complication, and it's not very common, but can occur, is a cardioembolic stroke, especially if somebody has a large anterior apical MI. I've seen this. They could have an acute stroke. Now, they could also go into atrial fibrillation and have, they could also go into atrial fibrillation and have a cardioembolic stroke with that. But you can, now we don't see this as much because the MIs are not as big. Okay, after somebody has an MI, you need to assess their ventricular function and determine, you know, how they need to be treated. And there's a multitude of things: beta blockers, ACE inhibitors, ARBs. Okay, if they have a large MI, okay, you may just go to a neprilysin inhibitor with an ARB and Entresto. They may need an aldosterone antagonist, but you need to assess their function and then put them on medications. Beta blockers have been shown to prevent early subsequent MIs. They can't be in pulmonary edema for you to start a beta blocker. The other thing is these people need statins. A lot of them are on statins, but if they're not on a statin, they should be on a statin. Their goal LDL should be under 70. That's to prevent subsequent events. Now, that's not an immediate post-MI complication. Okay, and these patients also need to be on an antiplatelet therapy, aspirin, and if they have a PCI done, okay, then they're going to be put on clopidogrel or Brilinta, and will be on what's called DAPT for a period of time. But the post-MI care, basically, and the post-MI complications, they're mechanical, and they're arrhythmia, and there's some subsequent ischemic evaluations also. Now, somebody could have an MI and they could have multivessel disease, and you know, they may need sequential revascularization. Most of these people just do not have single vessel disease. So mechanical complications are still there, although not as common. You need to monitor for arrhythmias. If they're in heart failure, you need to treat them. And clearly, a large MI, you're going to have heart failure, and the heart failure is going to need to be treated. Sometimes some of that function will come back, sometimes it won't. You have to be cautious. You have to be cautious for a stroke, and if somebody is in AFib post-MI, they're going to have to be anticoagulated. You need to think about pericarditis. And, you know, these are, obviously, you need optimal blood pressure control. The risk factor reduction is going to occur, you know, really a little down the line. If they smoke, you want them to stop. But these are the post-MI findings. Theoretically, you know, they could have a pulmonary embolism after this, and these patients admitted need to be DVT prophylaxed with the appropriate protocol. And I think with that, I'm going to stop. This is DAC in the trenches, post-MI complications. Thank you.